So we go now. Ladies, gentlemen, my pleasure to open this new session on analgesia and sedation. My name is Marc Léon from Marseille, France, and I have the pleasure to co-chair this session with Lorenzo Boll from University of Genova. So the first speaker is Professor Kotwis from Poland, but I don't know if she is here. Not she is.
Maybe swap the position.
And Rinaldo Bellomo is here, yes. So we can switch the presentation. So thank you, Rinaldo, for being
pleasure.
here and being
my
helpful.
My
so
pleasure. That's fine.
the talk is which analgesic agent?
Yeah. So there is a concept out there which is called analgosedation, which is the administration of opioid drugs to support the use of sedative agents such as propofol and midazolam. And it's a widely practiced form of assistance and support of sedation. There are lots of different opioid drugs that one could use: fentanyl, morphine, alfentanil, remifentanil, sufentanil. They've got different prices and different potential benefits or not. But around the world, as of really the last 3 to 4 or 5 years, fentanyl and morphine are by far the most common agents, probably because they're incredibly cheap. We published in 2019 the SPICE trial. Some of you might be aware of it. This was a 4,000 patients randomized controlled trial comparing early use of dexmedetomidine with usual care in the sedation of mechanically ventilated patients. And as part of that trial, of course, we collected a lot of information about treatment and about the use of opioids for analgosedation. And essentially, every patient in the usual care group and in the dexmedetomidine group got some analgosedation. And about 70 to 80% received fentanyl, and about 30% received some morphine as part of that ICU analgosedation. However, no studies have compared fentanyl with morphine to see if the choice of agent has a differential effect on outcome in this setting. Is there any reason to prefer one or the other? Do we have any reason to believe that they might have different effects? And that's an important question, I think. So the first thing to check is whether the use of narcotic infusions is also widespread in the United States, which were not part of the SPICE trial. And again, as you see there, that's also very common. So analgosedation as a process is very common. Some degree of morphine or hydromorphone or fentanyl is often coupled with other sedative agents. Both are very cheap. This is data from Australia. You can see that morphine and fentanyl are incredibly cheap drugs where I work, and I imagine they're very cheap where you work. So they're very equivalent in terms of cost. So using morphine or fentanyl because one of them is cheaper doesn't really make sense. They have different properties, however, which might have relevance to their contribution to outcome. And in particular, they've got a slightly different time to analgesia, but more importantly, they've got significant differences in metabolism. One is conjugated to glucuronides, and then the products of that conjugation are excreted by the kidney, and they have biological activity themselves. Whereas fentanyl is broken down by cytochrome 450, and it's really a more liver-managed kind of metabolism. So the excretion of the metabolites and the half-life of these drugs are quite different. And on the one hand, you could imagine that in patients with renal dysfunction, morphine and morphine metabolites would accumulate. And on the other hand, you could see that if you gave fentanyl for a long period of time, you would have this phenomenon called context-sensitive half-life, which is a function of the duration of infusion and the loading up of the lipid storage volume of distribution of fentanyl. So that if you stop the fentanyl after giving it for 4 days, don't expect to have a cessation of effect in 15 minutes. This is going to take quite a long time. As you can see there, potentially hours or maybe a day or two. So there is a possibility that these two agents, because of their different metabolism, a different half-life, would potentially have a differential effect on outcomes. So we set up a trial to ask this question, and the results of the trial were published in December in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine. The way we designed it is a cluster crossover randomized trial. So we had 2 centers that participated, and the centers were randomized to have 6 months during which all analgosedation was with drug A, which might have been morphine or fentanyl by random allocation. And after 6 months, they would swap to the other drug. And of course, the other center would start with the opposite drug and swap over to the second drug. So all the patients that were 18 years of age or mechanically ventilated and were included and were studied and allocated according to the center to either receive one opioid or the other, depending on the time frame and the center they were participating. And the trial was an open-label trial. So it was up to the clinicians to decide whether analgosedation should be administered, but once that was decided, then the period of treatment and the duration of treatment would be clinically indicated. The cessation of the drug would be as clinically indicated, and the only difference would be that for the period of 6 months, they would only be able to use morphine, and for another period of 6 months, they would only be able to use fentanyl. So this gives you a sense of the randomization sequence. So they're randomized in two different ICUs. You can see the number of patients we're talking about, and then you can see the number of patients that were excluded. And then you end up with each period of time in each hospital, a pretty equivalent number of patients, which added up to about 340 patients that received morphine for analgosedation, and about 340 patients that received fentanyl for analgosedation. So was the randomization successful in generating 2 groups that were equivalent as best as we could ascertain? And the answer is yes. On the basis of Apache scores and type of admission, use of vasopressors, source of admission, gender and age, these 2 groups were very nicely balanced. And this is, again, more information about their characteristics, PaO2-FiO2 ratio, creatinine, lactate, and everything else. And again, very good balance at randomization. Was there any protocol violation? And this is in the fentanyl arm. You can see that very little morphine was given. And that might have been given in some specific circumstances, very minute amount. And you can see the progressive accumulation of fentanyl over time. And this is the morphine arm, which again is identical to the fentanyl arm in terms of accumulation of the dose given to the patients with very little protocol violation. So the intervention clearly separated the groups dramatically in terms of what was given, and the randomization clearly created 2 groups that were comparable for baseline characteristics. So what about the outcomes? And you can see that the primary outcome, which was ventilator-free days at day 28, was significantly different, about 1 day of difference in favor of fentanyl. So fentanyl led to an increase in ventilator-free days or a decrease in the duration of ventilation. And also there was an effect in the duration of ventilation in survivors, and there was an effect on ICU-free days. So the effect of fentanyl in a positive direction was consistent across all patients, survivors, mechanical ventilation, and duration of ICU stay. This is the fraction of patients that were coming off the ventilator in the morphine and fentanyl group. And this is another representation of the proportion of patients that were ventilated or dying in the two groups. And you can see that not only do you have a favorable outcome on ventilation, but there is a bit of a trend there that those patients that were randomized to fentanyl appear to have a lower mortality. So this is the proportion of patients discharged from the ICU. So there is a faster time to discharge from ICU in the fentanyl arm. And again, this is time to extubation, again, faster with fentanyl. Is it because we used sedatives differently in the morphine versus the fentanyl arm? And it doesn't appear to be the case. When we looked at the use of propofol and midazolam in the two groups during morphine and fentanyl treatment, there was no evidence of differential use of sedatives. Did we treat people differently? Did being allocated to the fentanyl arm lead to a more sort of shallow or less intense or less deep level of sedation as measured by the RASS score compared to morphine? And the answer is no. There was no difference in RASS scores between the two groups. So the target and the delivery was equivalent. And really most of the impact was in patients that would normally stay ventilated for 1 to 2 days. That's where the big effect was in favor of fentanyl. And as I said, there was no difference in mortality, but the pattern, the survival was, as you can see on the blue line, was also in favor of fentanyl, but this was not statistically significant. Where was the biggest difference? Were there subgroups where it was particularly different in terms of outcome to receive fentanyl instead of morphine? The younger patients appeared to particularly benefit from the use of fentanyl instead of morphine, and the patients with renal dysfunction appeared to be particularly well served by fentanyl, which would make some degree of biological sense because of the fact that the glucuronides of morphine are renally excreted and are biologically effective themselves. So let me conclude by saying that analgesic sedation is common in ICU. Fentanyl and morphine are the most common agents. They have different pharmacokinetic and metabolic pathways, and these differences may lead to different clinical outcomes. We conducted a cluster randomized controlled trial, and we compared analgesic sedation with fentanyl versus morphine in about 600 patients, and we found that fentanyl led to better outcomes with more days alive and off the ventilator, more days alive and out of ICU compared to morphine. And these outcomes are particularly strong in younger patients and in those with impaired renal function. So these findings at this stage support the preferential use of fentanyl for analgesic sedation in ventilated critically ill patients. Thank you very much.
Thank you, and congratulations for this beautiful study. Is there any question from the audience? No? Yeah.
There's a lot of Dilaudid in the
Yeah, hydromorphone, yeah.
Hydromorphone is very, very common. I would say it may even be 40% hydromorphone, 60% fentanyl. What would your thoughts be, Chloe, not having studied in this trial, but what would your thoughts be, advantages, disadvantages? We feel like they tachyphylax less quickly to it, and that's why we like it in the long stay, especially COVID patients.
So there are these local cultures where people use different agents. You just missed it at the beginning. I showed the use of these different agents in the United States. There's a paper which is now a bit outdated from 2009 from Hannah Wunsch showing the use of hydromorphone, but that's still a minority even in the United States compared to fentanyl and morphine. It's got slightly different pharmacokinetic profiles. And again, I can't comment because in my neck of the woods, we don't use it. I practiced in the United States when I did my fellowship in Pittsburgh, and I saw it being used, and you can get a bit of a sense about it, but there really is no data to compare it in terms of the, even a sort of small studies or even, pharmacokinetic studies or, time to cessation, time to wakefulness in the ICU. So I can't really comment, sorry.
How do you explain that the young patient may benefit? Because higher creatinine, I understand.
Yeah, no, that's really kind of interesting. We're going to investigate this. We're doing a number of detailed analysis of the data. At the moment, we're looking at whether there's a difference in the use of antipsychotic agents and stuff. But it is possible that in the old, rather than being an effect of fentanyl, it's an effect of morphine, and that is that in the elderly, it is possible that physicians gave less morphine so in those allocated to morphine, because they're old and you think, the renal function isn't that good, even if the creatinine is okay, there's no muscle mass, just give it a little less. So we need to find out. So obviously that's an interesting question, but at the moment, we don't really know, and the hypothesis is not so much that it's a fentanyl, it's actually that the elderly people got less morphine in that situation.
Don't you think that fentanyl of morphine are too used in ICU? There is the opioid-free anesthesia and...
Oh, good Lord. I couldn't possibly say. I mean, there is, as I'm sure all of you are aware, there's this constant stream of discussion. Should we use more propofol? Should we use more opioids? Should we never use benzos? Should we use benzos some of the time? Or should we use dexmedetomidine? When should we use? Oh my God! We don't have any data. We don't have any data. So would the world be better if we never use or we use less analgosedation? I have no idea. But if you're doing, for example, if you work in a trauma unit, you'd have to give some kind of analgesia, you think. But for medical patients, I don't know. It's a subject of endless discussion at the bedside, but it's evidence-free because all the data is observational.
Yeah.
So we need to do more randomized controlled trials. And you could say, well, okay, now we've done this. Can we do a randomized controlled trial of less analogous sedation and more use of who's to know? The combinations are endless, and I have no desire to make any statement about which one is better because I can't.
Yes, question.
Hi. So, given this information, how has this changed your own practice? Do you just never use morphine now for this indication? Just always use fentanyl?
Yeah, morphine is gone.
Yeah, morphine is gone. Okay.
Goodbye. Sad. Some people are really sad. They're missing it. They used it all of their lives. But, we said, look, we've done this trial. It's in our hospital. The two centers are our hospital. The evidence is there. Maybe if we use morphine better or more wisely, more astutely, more intelligent, but obviously we can't, because if we could, there wouldn't be any difference. And so, it's gone. Yeah, there's the little, we miss you kind of little cards and stuff, yeah.
With all morphine.
Yeah.
Just to comment to your comment, I feel like we probably lose too little opiate now. At least in the U.S., there's been this huge pendulum swing against opiates, right? It comes from our opiate epidemic, which I know the U.S. is maybe the worst of, but also from the opiate-free anesthesia, so a lot of us are anesthesiologists. I feel like we far undertreat pain. Having been a patient in the last 2 years a number of times, both in and out of the ICU. People are highly reluctant to give even truly painful events pain medicine any longer. And I feel like we are creating suffering amongst our patients because we're afraid of creating people addicted to opiates. And I think propofol is a big offender, right? Because it doesn't treat pain, but you have no assessment. And so that's when you'll hear me propofol in a minute, but I think we undertreat it now. I think that's the opposite.
I think it's really cool, and I think it's really real, and it's a real issue.
Yeah.
And I just want to say that in my world, we now have a system that follows people up electronically whenever they get opioids. And so following the trial, we're now following people up to a year to see how many people are on opioids after being treated and with morphine or fentanyl, whether there's a relationship to the dose, cumulative or mean, and whether and how they compare to the previous period or into patients that only received sedatives with no opioids. So there's a whole lot of very fruitful investigation to try and understand whether giving these drugs really does, as some people fear, contribute to opioid dependence, or whether it's completely invented.
Yes, but we need your result.
Yeah, well, give me some time, yeah. We're plodding away, yeah, okay.
So thank you again for this night talk. I think we can move to the next speaker, Professor Gottfried from Poland, which will talk us how to assess pain.
Thank you very much for the invitation. I'm very sorry for being late. I was in the other session and the discussion was a little bit long. So how to assess pain? That's the mainstay of assessing pain is the mainstay of proper therapy, and I declare no conflict of interest. So why do we even discuss the subject? It is has been shown that over 80% of the patients will suffer in the ICU if we do not assess pain and if we don't treat it wisely. And the most painful procedures that we're doing is the arterial line insertion, the chest tube, and drain removal, but also mechanical ventilation as such. Endotracheal suctioning is the most powerful painful stimulation, and also repositioning in bed. So the difficulty with pain assessment arises from its definition as defined by International Association for the Study of Pain. It is unpleasant sensory and emotional experience, which means it is 100% subjective. Experience of pain is multidimensional, but not purely physical. And we all know that pain distress and untreated pain or undertreated pain is associated with worse outcome. So, as has already been mentioned, inadequate pain assessment leads to inadequate pain management, to either analgesic overdosing or analgesic underdosing. With underdosing, we obviously have a patient in discomfort who's non-cooperative. This increases the need for sedation, might cause confusion, and also leads to prolonged mechanical ventilation times and higher mortality. So, a large variety of complications. Now, with analgesic overdosing, the opioid-induced hyperalgesia and long-term use is one of the mainly discussed problems, but also on this side we have prolonged mechanical ventilation and prolonged ICU stay. So neither is well. And our aim at the ICU for all the members of the team should be to provide comfort to the patient. Now, in the guidelines from 2018, those elements that are regarding the pain assessment are very, very straightforward. So what should be using? Patient self-report of pain is the reference standard, so the gold standard for pain assessment in patients who can communicate reliably. And this is the minority of our patients. So what about those that cannot communicate reliably? We should be using in those that are unable to self-report pain, we should be using behavioral pain scales, and those that have been validated in the majority of the studies is the behavioral pain scale and the critical care pain observation tool. But there are times at which we will not be able to use either of those, and we need extra help. And that there has been mentioned the proxy reporters, which is in those patients that we're not fully able to assess pain, we should be asking the family for help, but that still underreports pain. And obviously the physiological measures as sole assessment is not enough, so research should be done in that report. Now, with the self-assessment tools inside and outside of ICU, that should be done repeatedly, firstly upon admission to assess the character, duration, location, and the severity of pain. And for that reason, we use numeric scales with the visual component as the most widely used, from 0 to 10. But bear in mind that those patients who are deeply sedated, who are sedated but cooperative, with delirium, with visual or hearing impairment, or unable to follow commands, will not be able to use the scale. And as I said, vital sign assessment is not adequate for pain, as we know different conditions for which patients are treated in the ICU cause tachy or bradycardia or other underlying problems. So the ABCDF bundle mentions the CPOT and the BPS as the mainstay to assess pain and ensure adequate pain control, but of course it is not enough to assess. It is more important to assess and care for properly. Behavioral pain scale, the difficulty with its use is that it's based on facial expression, upper limb movement, and compliance with mechanical ventilation. So for those patients who are, for whatever reason, due to the use of neuromuscular blockade or any facial damage, unable to show facial expressions or upper limb movements, we will not be able to use behavioral pain scale reliably. And the range is between 3 and 12. And there has been studies showing that even in those centers that have standardized management protocols, that assessment tool was used in minority of the patients, 1/5 of those. So many patients suffer, especially those that are deeply sedated. Now, the CPOT has been introduced and validated in different languages. It is a system based on a scale between 0 and 8, comparable to the BPS, but again, facial expressions and body movements will preclude using that scale in those patients who are, for whatever reason, unable to move. But this scale can also be used in those patients that are vocalizing. So that is a scale that can be used for communicating extubated patients. Now, with the behavioral pain scales or any pain assessment, the neurosurgical population with brain injury is this most severely, I'd say, left out for assessment. So this is a study by Céline Galinas and her team, French-Canadian and English versions of this neuro-CPOT have been used, and it has been shown that the cutoff scores for those patients who are suffering from brain injury are similar to the other populations with a cutoff score of above 2 and above 3, adequately reporting pain, self-reported pain above 5, respectively. Now, what are the evidence gaps identified by the PADIS guidelines? That has already been mentioned. So the use of proxy reporters, which means family and friends, and also the scale should be provided in the given language of the ICU and should be revised. We need to bear in mind that those scales might be unreliable in patients who are sedated with a target deeper than Richmond agitation sedation score less than -4. So what other technologies have we got to help us assess the pain in the ICU? The heart rate variability and the pupillary dilation index. So these are so-called, or we hope they will be, objective assessment tools for pain evaluation. And within that group, we have analgesia nociception index, nociception level, pupillary pain index. So the concept behind that is that the electrophysiological monitoring tool is the basis for the analgesia nociception index, and it evaluates this. This is the spectral analysis evaluation of the heart rate variability. And the analgesia nociception index varies from 0 with minimal parasympathetic tone and 100, which is the maximal sympathetic tone. And here we can assess the mean ANI or the instant ANI. And this is a validation study or the diagnostic accuracy evaluation performed by the team led by Shank and colleagues, and it has been shown that the incident, not the mean ANI, but the incident ANI has the highest benefit for excluding those patients with significant pain. Another tool is the nociception level index that, according to the manufacturer, is able to objectively assess pain in those patients who are unable to communicate, and it relies on a non-invasive finger probe which acquires physiological signals and then transforms it internally through pain-related physiological parameters. Data is analyzed by artificial algorithm that is it is known for the manufacturer, and a number is produced between 0 being no pain and 100 being extreme pain. So it's a non-linear combination of different elements: heart rate and heart rate variability, plethysmography, skin conductance fluctuation, and their time derivatives. And this was one of the initial studies, feasibility study, that has, on a small group of patients, 28 patients, that has shown that the NOL values were higher during, and they have chosen endotracheal suction as the most painful intervention in this patient population. So that has been compared with the quiet rest time prior to suctioning and after the suctioning. And that scale, the NOL, has been validated against the CPOT, and the NOS values were higher as compared with correlated with the CPOT values. So the authors concluded that this, the NOL could very well discriminate between nociceptive and non-nociceptive interventions. And this is another study that has looked at a similar group of patients, but used other interventions, other painful interventions, such as nociceptive procedures, and here it was the chest tube removal. So here 54 patients were included in the analysis, and it has shown that the self-reported pain intensity and pleasantness was associated with the NOL, but not with anxiety and CPOT scores. So the cutoff point has been shown to be discriminatory between nociceptive and non-nociceptive procedures at the cutoff between 22 and 26. Another, physiology-based parameter is the pupil size that we know balances between the parasympathetic and sympathetic system, and here the pupil reflexes are assessed in comparison during a noxious stimulus and during exposition to light. So the pupillary reflex dilation estimates the level of analgesia in response to a painful procedure or to a calibrated noxious stimulus. And in that regard, the tetanic stimulation has been used in those patients. So the PPI is a novel index derived from pupillary reflex dilation, and it is the variation of the pupillary diameter over an application of a noxious stimuli. It ranges from 1 to 10, with 1 being low level of pupillary reactivity with high level of analgesia, and as opposed to 10, high level of pupillary reactivity with low level of analgesia. And there has been validation studies performed with very painful interventions used with, and it has been shown that a painful stimulus of applying a tetanus stimulation of 20 milliampere was sufficient to show a difference, and in this group of patients, also a stimulation of 40 milliampere was used, which was over the scale. So the PPI has been evaluated or validated against the behavioral pain scales, and this is a study by Mark Winkler that was a proof of concept that the PPI has a good discriminatory value for pain assessment in sedated patients and who were assessed with the behavioral pain scale. So to conclude, we as clinicians in the ICU should assess pain regularly using self-report in those patients that communicate with us. So key to success is light sedation and the cooperative patient. If the patient is unable to cooperate and communicate, then the guidelines recommend the use of behavioral pain scales, but hopefully nobody uses the vital sign assessment as the sole surrogate for pain assessment, and which should be conducted regularly every 2 to 3 hours. And hopefully, in the future guidelines, more physiologically based tools will be available, as we must understand that pain assessment using the scales that we have available right now might be time-consuming and might involve the whole team, whereas quantitative measures will be easier and faster to use. So with this, I thank you.
Thank you for this comprehensive presentation. I have a rather naive question, probably. You've mentioned these emerging multimodal systems to monitor pain. How should clinicians interpret these parameters in the context of deep sedation or the use of large amounts of propofol? And how should we react to these numbers in the context of a highly sedated patient?
Well, this is the concept that those objective measurements and assessments and tools will let us assess those patients who are deeply sedated, who have neuromuscular blockade, and who also are brain injured. So this, well, according to the teams that have been working on that so far, because there are so many parameters and high technology is being used to evaluate the gathered information, it might not be just one tool that we will have to use in those patients, but combine different elements of assessment. But this is the idea behind it, that we will be able to assess those patients who are deeply sedated.
Thank you. Is there any question? Maybe one?
Can I? Yeah. Thanks for this review. And, you know, all the pain things are validated in people that can communicate thereafter as to whether the signal that you were using was associated with a particular level of pain. And so in the patients that we cannot assess, it's actually impossible to have a validated tool. You know, you can infer from what you've seen in those that could tell you, but in the ones that can't tell you, it's impossible to validate anything, because it's impossible to know what it is, that in this complicated psychosocial, emotional, physical thing that we call pain really is in their minds. As I say to my fellows, I'm in immense pain as soon as I walk into the ICU. You can see it on my face and stuff, and I can communicate it with you, but in those patients, it's very, very difficult. And it's a little bit what you were saying before. You're on propofol, you're sedated, you're feeling pain, no one knows, you can't communicate it. The tools, you may be able to display a grimace or anything, but it's really, really difficult. And, that's 50% of my patients. And that's really, we're faced with this conundrum. They are the sickest people, and we cannot know what kind of pain they're feeling or not feeling. It's a nightmare from my point of view, because as a clinician scientist, I have no faith in any of the tools available to me, including my own opinion, which is, of course, pathetic. And I just have no idea.
I cannot agree more. I agree with you 100%. And that's based on the studies that I have done. We have done a Polish validation of the BPS and the CPOT. And I absolutely 100% agree with you. There are some rules that you have to follow in terms of evaluating the behavioral scales against patient self-assessment, but you can question the patient self-assessment. That's the primary difficulty. And I said this earlier, I also run a pain clinic, and those patients are not sedated. Those patients are fully cooperative. They should be using, at least numeric rating scale or the visual analog scale. And for some of those, the intelligence level is not enough to do that. For some, the psychological aspect of their pain is so predominant that they cannot focus on a number. And I'd say for a majority of those patients, it takes at least 2 visits to focus on what we're actually talking about. And for those patients, we're just expecting our patients in the ICU, let's say, to produce a number. And there are so many layers to pain that you cannot identify. The psychological side is one, but the color, I call it the color of pain. And then to provide what they really need. Not everybody needs fentanyl. Many people will need neuropathic pain treatment. And we're not assessing, I have a feeling we're not assessing that with these tools. Thank you.
Thank you, Dr. Kotfis. So now we move to the next speaker for a talk, performing neurological wake-up test in sedated patients. And I introduce Dr. Victoria McCready from University of Toronto.
Thanks very much, Lorenzo and Mark, and thanks to the organizers for inviting me here. So I'm going to shift focus a little and actually talk more about brain injury patients, which Professor Kotfis alluded to in her talk, about the fact that so many of those patients are missed out of classic sedation and analgesia studies. I have no conflicts of interest for this talk. So when we talk about the neurological wake-up test in acute brain injury, I think of it very differently to how we talk about daily interruption of sedation. You might also see it referenced in the literature as spontaneous awakening trials or protocolized sedation. And we do have good data that, at least that in a general ICU population, when we use those sedation minimization strategies, is associated with a better outcome, less duration of mechanical ventilation, less morbidity, and less length of stay. But really, so many actually brain injury patients really are generally excluded from all of those studies. And the way that we are using those sedation vacations are quite different. They're usually paired with spontaneous breathing trials, where when we do it in our neuro patients, we're really doing it as an avenue to then go forward and try and do a neurological wake-up study. So it's really hard to apply all of this literature to our brain injured patients. So when I talk about a neurological wake-up study, I'm really talking about different stages, and at every point I may abort doing this. So I start off with first assessing whether they're stable, and that's not just your systemic parameters, but also their neuromonitoring parameters. And at a baseline, I think the majority of us do monitor ICP and CPP. Then I go on to my sedation interruption or sedation vacation. And we're really waiting for them to awaken or really to arouse, because they're not awakening from a slumber or sleep. They're trying to arouse from a comatose state due to their brain injury. And throughout that, I'm watching to see that their ICP and CPP are okay. Then I'm moving on to the neurological wake-up tests. And as a bare minimum, we should look at level of consciousness. In my centre, that is GCS, and others, you may use Fourscore or other measures. Pupil diameter and light reflexes, and then looking for any focal neurological deficits. And again, throughout this, I'm checking to see that their ICP and CPP are stable. And as I said, throughout any of these points, I may decide to abort for concern over systemic or cerebral hemodynamic parameters. And then really, I'm making a decision at that point after if they pass their neurological wake-up test, not pass, but at least I'm able to examine them. And then I'll go forward and decide whether either I'm going to increase the aggressiveness of my care, really trying to target their ICP, or maybe in a more classic spontaneous awakening trial, an SBT, I may start to wean the ventilator and aim for extubation. So when we look at this, brain injury patients have all the general indications for analgesia and sedation, control of anxiety, comfort, tolerability of the endotracheal tube, agitation. But within our brain injury patients, we also have these brain-specific indications for our sedation to try and reduce their cerebral metabolic rate, help with their ICP treatment, stop seizures, and help with either targeted temperature management, or we're going more towards avoidance of fever. So we're really using it as a neuroprotective agent, which is quite different to our general ICU patients. So on one hand, these are all the different types of mechanisms I'm going to use with my sedation, really trying to target reducing ICP. Fever control has, as well as direct effect on ICP, may have other effects, like trying to stop the excitatory cascade in cytokines, but does have effect by dropping the CMRO2 and energy metabolism to help with ICP. So I really find there's these competing goals with sedation, and when I try to decide whether I'm going to do a sedation vacation and wake up patients. In one hand, on the green side, I'm going to use sedation to try and control the CMRO2 and energy, try to control shivering and prevent seizures. And they seem really important. But on the other side, I'm thinking about stopping my sedation to do a neurological wake-up test to allow me to, one, assess them clinically, look at their gross structural integrity of their nervous system, use it as a way of brain injury severity. We still use very rudimentary GCS as a way to, or severity of traumatic brain injury, and help as a prognostic tool. And you might say, well, the stuff on that left side, the green column there, seem really important, so why would you even actually attempt to wake them up? Well, we know that when we obscure the clinical exam with sedation, we actually miss some very important findings. We have to go back and look at the old neuroprotective trials. So this data is pretty old, but if we look at things like the NMDA antagonist trials like Selfotel and then Dexabinol, we can see that neurological worsening, when they examine and try to see, can be up to 44% in the acute remission period. And it really is in the first couple of days. So it's up to 40% in the first 48 hours. And what do I mean by neurological worsening? Well, so there's been a resurgence of trying to look at what we mean by that. And we look at the Seattle conference for traumatic brain injury, where the group got together to try and make protocols, knowing that the most recent Traumatic Brain Injury Foundation guidelines actually were devoid of protocols, and we all love to follow a protocol. So the CIBIC group, and as well as the Crevice working group, came up with these criteria for neurological worsening. And the one that we can see at the bottom, herniation, which is continuously monitored, is really an end stage there, right? And you don't really want to get to that. You've missed the ball there if you get to that point. But for those that you have to hold the sedation, we're looking for the GCS and focal neurological deficits. And those are the ones that I really know are quite important to detect neuroworsening, and I have to hold my sedation for that. So what are the most popular or the most frequent things that we find when they're neurologically worsened, when we do a neurological wake-up test? Well, the majority are, you might say, pupillary results, right, exam, and maybe you don't need to hold sedation for that. But a majority of them, we find it's a drop in their GCS and their motor score. And we find that those who are deteriorating in those first couple of days, the majority of them is due to increased intracranial volume and intracranial hypertension. And I suppose this is the golden bullet for neurocritical care, which is we find that those who don't have neurological worsening have a much better mortality or survival and a much better favorable outcome. And I suppose we're always trying to hunt to see if we can detect that neuro worsening, reverse any reversible brain injury, and improve outcome, which we still haven't found that magic bullet yet. So that leaves me with this basic conflict when I'm thinking about sedation in my brain injured patients and the neurological wake-up. First, does the clinical information obtained from the neurological wake-up justify us inducing this stress response? Does the stress response actually impact overall outcomes? And in this modern era of multimodal neuromonitoring and access to a lot of neuroimaging, is a neurological wake-up test really necessary to identify these important clinical or physiologic deteriorations? So we've seen, at least in human studies, and it is not great data, it's a great level of evidence, it's really nice studies, but the level of evidence isn't great. So these are single center studies, mainly from Karen Skoglund and Nicholas Marcus and Raymond Hellbach from Columbia have published some really nice studies, physiologic studies looking at this. And we can see that whenever they wake patients up, brain injured patients, we can always see this stress response of increasing heart rate, blood pressure, transient rises in ICP and CPP, and sometimes differential results in their brain tissue oxygenation and cerebral microdialysis. If we look a little further and closer, I've just pulled out some of the nice work from Raymond Hellbach, and we can see here hemodynamically, the gray shaded area is when you start to do your sedation hold and you're starting to do a neurological wake-up test. And we can see in all of these a rise in each of the parameters. The black boxes are when the trial has been aborted, and I just wanted to pull out the trial aborted here as your ICP is going up to 25. They stopped it, restarted sedation, and all of those patients had a dramatic, significant drop in their ICP. When we look at brain tissue oxygenation, again, we can see that the brain tissue oxygenation drops in a certain proportion of patients that we, I think, get nervous enough about that we have to abort the trial and restart sedation. But the thing you're probably really asking is, well, what's the percentage of we get through that, we weather the storm, we're not concerned enough to restart sedation, and I actually find a difference that I act on? And at least within Professor Hellbach's study, they found actually there was only clinically relevant information in one of those trials. There isn't any outcome data from this really reported between the trials because actually it was done repetitive trials in 20 patients, so there wasn't able to look at controls versus otherwise. If we move on to looking at one by Karen Skoglund, again, just showing you the changes in ICP and CPP, but I think on the side here on, what's that, my left, your right, you can see temporal changes on what happens with ICP during the stay, and you can see that actually traumatic brain injury with that secondary injury process seems to have a more significant rise in the ICP. If you see on the y-axis, it's actually a funny measure, it's peak ICP ratio to their baseline ICP when they came in. So it's more of a change in ICP, as opposed to subarach who come in with their global cerebral edema from their initial subarach hemorrhage and then dropping within the first 3 days. So it's always important to think where they are in their time course. So overall, when I look through those studies, and this is not in any way a systematic review, we can say that about 30% you're going to be unable to do a neurological wake-up test. In those that you try to do it, another third you're going to abort. And those that you do manage to complete it, about 50% you'll actually see an increase in the GCS. So make you feel good that things haven't gone bad. The majority in these studies, they all were exactly the same and no further action. And there was that one trial that I said caused a clinical actionable event, ordering a CT. So the patients that I don't wake up is people with high ICP, CPP problems, people with hyperthermia or who are actively trying to cool, barbiturate treatment, status epilepticus, or the classic hemodynamic instability or ARDS problems. If we look at actually the frequency of neurological wake-up tests, this is data from Sweden, Norway, and Denmark. It's pretty old, but they got 100% response rate to their surveys in 16 of their neurocenters. And you can actually see there with Norway, the majority of them never actually do neurological wake-up tests, while as some in Sweden were doing up to 6 a day. And I think this is very probably city, regional, country specific. We have a practice in our hospital of doing it sometimes every hour, which after 7 days and you come on service, it's time to reevaluate that for the amount of delirium inducing that must cause. You might think, well, those people in Norway, they didn't do it so much because they had lots of neuromonitoring. Well, they probably had about the same as what we have as a baseline CPP and ICP. I would say concern that sometimes you can actually have brain herniation outside of ICP elevations, which maybe you would clinically detect if you woke them up, although they are commonly linked. The choice of sedative agents maybe also impacted this survey here, where you can see that Norway, majority of them use midazolam, so maybe building up in the system and not wearing off like propofol, allowing you to do that quick assessment. This is not per se a neurological wake-up test because they're not heavily sedated and intubated, but it's at least looking at the frequency of neurochecks after stroke. And this is a study by De Leon Benedetti and colleagues, and they were doing them nearly every hour in the first 72 hours post-stroke. And while about 45% of those neurochecks detected a worsening, actually just as much was detected out with those neurochecks. So really, we may need more novel monitoring strategies to identify neuro worsening, and that's what we feel in neurocritical care with neurological multimodal monitoring, which for the most part is quite invasive, and we're probably not going to, in these patients who are not in an ICU environment, start putting probes in their brain. So this leads me on to more recent work from the CIVIC guidelines or the consensus statement that was trying to help us understand patients that we might hold sedation on. They weren't able to come to an agreement, so they created heat maps and a traffic light system. And this is quite complicated, so I'm just going to summarize it here. But along the top, you've got your Glasgow Coma Scale, normal, abnormal pupils, and then your Marshall classification. And then you can see that this is patients who are on tier 1 therapy and they've not had any higher level tier therapy. We can see that I would say as a rule of thumb, proceed if they've had ICP acceptable for 24 hours, although proceed with caution with those with a lower conscious level and a higher Marshall classification. Just to remind you about the tiered levels, so tier 1, which we just talked about, was maintaining ICP and CPP, strict CO2 targets, and potentially hyperosmolar therapy. And the level 2 and 3s are really once we get up into phenobarb comas and decompressive crani. So quite a lot of intervention. They have 2 other heat maps here. One is when they have had prior history of tier 2, 3 therapies, where in this you would proceed with caution if it was 24 to 40 hours. Do not proceed if it's within 24, 40 and a lower GCS. And then finally, this is people who are on tier 2 and 3 therapy. Again, the big caveat is in the first 24, 40 hours, really either don't wake up or proceed with caution. So just to sum up conclusions, the most fundamental neuromonitoring tool in acute brain injury is the clinical exam, and that's why we persist in trying to wake them up. But titration and interruption of sedation, you have to really weigh up the risks of interrupting it versus the potential benefits of being able to examine them. And then I would always just posit to reassess the frequency of your neurological wake-up tests. So I'd say thank you very much, and is there any questions?
Thank you for this talk. Any questions from the audience?
Oh,
yes. Microphone, please.
Hi, so question. I'm actually an intensivist in Norway, and I'm afraid to say we haven't changed as much as we like. But in trying to progress, I would suggest, when you look at the literature, it seems like we're looking for only neuro worsening, but don't you think that it could also have a potential important role in and showing us that we might have overestimated the initial injury, so that actually you do a wake-up test and then you realize the patient isn't as brain injured as you thought, and you've just saved that patient from a lot of risk being deeply sedated in the ICU. Isn't that another important reason to try when it's safe?
Yeah, that's a really good point. There was a lot of emphasis in my talk about neurological worsening, but in that first couple of slides, you might have seen some of the benefits of doing a neuro check, and one was for prognostication and injury severity. So yes, you're right. The injury severity may be not as bad or worse than what you initially expected, vice versa. I suppose we tend to focus so much on the prognostication on the worst side or worsening. There's been a move in cardiac arrest that I think Laurie Morrison might have talked to him before about trying to identify the good outcomes in prognostication, and the same here for all other types of acute brain injury. So yeah, I agree with you.
Any other questions? Yeah.
Even if you have assessed and found the deterioration, you're going to confirm with the CT scan, isn't it? And then intervene. And with this current era where the bedside CT is available, why you want to stop sedation and see? Why don't you do everyday CT? Or if there's any clinical deterioration for the pupillary size, do the CT and then proceed. And very well the question that you need to assess the stoppage of sedation or the stoppage of the intensive therapy. Yeah, there may be ICUs where they're not monitoring ICP, but they're basically monitoring the vitals and other indirect parameters. So in that situation, what will be will you like to, in my ICU, I do every day one CT. If there's any, unless there's any reason to do, I may do more frequent CT. Yeah, somebody may say, why you're exposing the radiation to the thing, but in first few days when there is a chances of ICP like traumatic brain injury, third day is going to deteriorate. It's better to detect the earlier chances of ICP when we don't have a monitor in place, and take the necessary action or craniotomy and anything else.
Yeah, gosh, there's a lot there. So I'm going to try and unravel it. So first would be, I need to come work in your centre because I don't have bedside CT, and I work in Canada, in Toronto, and we don't have that. Second would be, you make a great point about, so the CREVIS working group actually came out of the ICE, didn't it, the BEST trip, where they were actually, they were doing what we thought was a trial of ICP monitoring, but it wasn't really. It was a trial from Randy Chestnut of how to manage high ICP through two different ways. One was through ICP monitoring and invasive monitor, and the other was the ICE protocol, wasn't it? And that ICE protocol standard for clinical evaluation and imaging, clinical evaluation, ICE. Oh, sorry. So clinical examination was just as important as the imaging in the ICE protocol. And they found throughout that, compared to invasive ICP monitoring, that bundle of care meant that you had no difference in outcomes. So no worse, no better. You probably got more therapy, so there was more targeted therapy with ICP monitoring, but in resource-limited settings, for sure, relying on CT and clinical exam has been shown to be just as good. There was something else I was going to say. I can't remember. Sorry. Did I answer all your questions? The other one was, if you ever talk to some of the neurosurgeons and neuroradiologists, so we got quite CT happy for our subarachs, looking for delayed cerebral ischemia, and we love CTA, CTPs. And the neurosurgeon will come round at 6 a.m., order a CT, they'll go and come back before we even realize it. We'll round at 9 a.m., and then we'll order another one. And they sometimes get a lot of CTs to the point where they'll have a halo of hair loss where they've had so many CTs. Now, you might say, is it better to be alive with a neurologically intact and a halo of hair loss? But I think there's probably a happy medium. So,
Thanks very much, Victoria, for this nice discussion. My pleasure to invite again Professor Gottfried to discuss the role of sedation management.
Thank you very much. Now on time, much better. Okay, and again, I declare no conflict of interest. So first of all, we need to identify why do we need sedation in the first place. And we believe it is to better allow a patient to adapt to mechanical ventilation. And of course, if we're using neuromuscular blocking agents, that's that's 100% of comfort. To reduce patient ventilator asynchrony, to reduce ventilator associated lung injury, reduce oxygen consumption, and facilitate tolerance of the endotracheal tube, and suctioning, and mobility in bed, and so on. So we need to identify that the whole range of patients and conditions our patients are in, then different levels, planes of sedation will be required. If we decide that the primary goal is to keep the patient safe and comfortable, then we need to identify those that will definitely need deep sedation, and that's severe brain injury with elevated intracranial pressure, those surgical conditions that require immobilization for patient safety. If there's severe dyssynchrony, or to prevent patient awareness during neuromuscular blocking agents infusion, status epilepticus is also one of those conditions, and again, surgical conditions that require immobility. Now, we also know really well that the lighter the sedation, the better the outcome, because that's associated with shorter mechanical ventilation time, reduced hospitalization, both as the whole hospitalization time and the stay in the ICU, but also a reduction in infectious complications, meaning ventilator-associated pneumonia as an obvious consequence of shorter mechanical ventilation time. But also, lighter planes of sedation mean less delirium and less immobility, coordinated consequences like ICU-acquired weakness. So there have been multiple studies here showing, a study by Shahabi, showing that deep sedation is associated with worse survival at 3 months in mechanically ventilated patients, and that allowing the patient to go into a spontaneous awakening trial, so getting the patient into lighter planes of sedation and allowing them to breathe spontaneously, that increases survival at 1 year. So not just the short-term mortality is improved, but also the long-term mortality. And the initial guidelines have produced, the Society of Critical Care Medicine guidelines have produced statements both in 2013 and 2018 that the target sedation should be light sedation and institution of spontaneous awakening trials, and there have been multiple studies showing that effect. So the ABCDF bundle talked about today and used in the ICUs means that we should be targeting light sedation and avoid benzodiazepines when necessary, and the question of using an agent as such, whether dexmedetomidine is better over any other agents. So we know it's better than the benzodiazepines, but is it better than propofol? That has not been shown. When we, apart from choosing an agent and the targeted level of sedation, we also need to evaluate the patient needs in terms of ventilator and asynchrony, the actual oxygenation, and whether they are with the endotracheal tube or tracheostomy, and whether there are other comorbidities. So as I said, there is a range of patients and a range of sedation approaches. For those that are receiving neuromuscular blocking agents, we would target deeper level of sedation with a RAS or ASS, confirming deep sedation just to avoid unwanted harm to the patient. And we can only lighten the plane of sedation after the neuromuscular blocking agent infusion has been stopped and the patient has metabolized the drug. Now, it has also been shown during the COVID pandemic that those patients that had acute respiratory distress syndrome and required neuromuscular blocking agents were prone. Our approach was different, and they were in deeper sedation for longer, and that was associated with increased mortality. So in these groups of patients, again, lighter sedation increases survival. Now, when talking about sedation management, we would like to tailor the choice of drugs to the patient needs. So bear in mind different pharmacokinetics and pharmacodynamics of the elderly patients with reduced clearance and increased sensitivity to different agents, but also the multi-morbidity and the previous on-admission polypharmacy that the patients were prone to. With the younger patients, many of those might require higher doses of analgesics or sedative medications and will probably have a lower risk of delirium. Also, the previously today mentioned the chronic opioid use syndrome, that's a group of patients that might get admitted to the ICU who are chronic opioid users, and their requirements will be higher. Now, with those patients who have an exacerbation of a chronic disease, same as the elderly, the metabolic derangement and the metabolic capacity of the liver and kidneys will be abnormal. So in terms of the sedative choices, of course, we would like to be aware of the consequences of the drugs that we use, and with the prolonged propofol infusions causing hypertriglyceridemia and the PRES, and also with dexmedetomidine, the possibility of bradycardia and hypotension. Obviously, midazolam and other benzodiazepines have been linked causally to the higher incidence of delirium. And volatile agents, that's a very broad subject, and these are probably underused in modern ICUs. So with the propofol, as has been mentioned, the risk for hypotension and hypertriglyceridemia, that has been brought into attention again by the COVID pandemic, as the high TG levels have been associated with the infection and with the disease and liver dysfunction, but that has brought the subject back into attention. So when we compare different agents, benzodiazepines, propofol, and dexmedetomidine, it has been shown that sedation with dexmedetomidine was associated with lower in-hospital mortality rate than sedation with midazolam or propofol. But, of course, no sedation, when we compare to no sedation, so the lighter planes, the use of midazolam, propofol, or dexmedetomidine was associated with longer hospitalization, both in the hospital as such and longer ICU stay. Again, a different range of patients. Those patients that are awake and requiring prone positioning, dexmedetomidine might be an option for those patients to tolerate awake prone positioning, and that's another lesson learned from the COVID-19. Now, this is a very recent study published in December 2021 from a Chinese group that they have looked at a very specific population of cardiovascular patients suffering from acute myocardial infarction. And as we know, we might potentially fear the use of dexmedetomidine in this group of patients due to bradycardia or hypotension. But it has been shown that dex is the preferred sedative in that group of patients as well. Now, if we use sedation in our patient, it is not without a consequence. Some of us are actually, or all of us, might have a group of patients, and I'm sure recall that group of patients when delirium was actually iatrogenic and was 100% related to the oversedation or the sedation agent given. So if we identify those patients in whom delirium has been associated with sedation, for that group of patients, the outcome is the best. They actually usually have a good recovery and return home, and also their mortality is lower. Now, as I've referred to a couple of times already, the past 2 and for some 2.5 years of the pandemic has brought us new light to the sedation practices that we have been providing to the patients. So pre-COVID, I would say studies have shown that a targeted RAS of 0 and having an awake cooperative patient was what everybody had at the back of their mind if the patient did not, for the reason mentioned previously, require deep sedation. Now with COVID-19, because there were other factors involved, like cross-infection and lack of PPEs, it turned out that to facilitate care, much deeper combination, I'd say, more mixtures of drugs and deeper planes of sedation were used, and that actually led to increased incidence of delirium. So that is the iatrogenic effect of our treatment, as shown in the COVID-AD study. And also, both the number of medications used in the ARDS has decreased the survival rate. So compared with the patients matched with acute respiratory distress syndrome, the patients with COVID-19 received higher doses of sedatives, which not only prolonged their ICU stay and their coma, but most of all caused higher mortality. Now, protective ventilation is not just a new subject. It did not arrive to us with COVID-19, but if we use sedation to facilitate protective ventilation, we still need to have it in tiers or have it as levels. So the mainstay of therapy will be to aim for an orientated patient that is cooperative, and if anything deeper for ventilation to take place is required, then we should target it step by step to deeper planes of sedation by increasing the doses of the drugs known not to be deliriogenic, which is propofol and dexmedetomidine, and of course this should be combined with adequate analgesia, as has been stressed earlier. Now, this is an excellent chart from a paper by Sanjita Mehta and Claudia Spies that covers in one place more elements for sedation that we usually think, and it points out that sedation as such is also to cover anxiety or treat anxiety, to treat unnecessary agitation, to deal with sleeplessness, because some of those patients might need sedation only for a good night rest, and this has to be done with proper assessment of pain, as we have discussed previously, and proper assessment of the sedation depth. But it also, so to say, proper sedation requires non-pharmacological interventions to allow us to use less sedative drugs. And apart from that, to spare the use of sedative infusions, not only opioids and non-opioid analgesia might be in place, but all the other drugs that are not used to treat delirium, but are used to lower the rates of agitation and to stop patients from self-harm. So if we advance it from bit by bit in 10 steps, the first one would be to prioritize pain with proper assessment and management. If deep sedation is not a prerequisite, then we should target a RAS of 0 and have an awake cooperative patient hopefully shortly after intubation. analgesia and sedation should be symptom-based and combine both pharmacological and non-pharmacological interventions. When deep sedation is necessary, we should de-escalate as soon as possible. For assessment, validated tools should be used validated tools and reassessment. The non-pharmacological elements have already been stressed. We should be avoiding benzodiazepines, but bear in mind those patients that might have benzodiazepine withdrawal or opioid withdrawal. And part of the sedation management is removal of the irritation, which is unnecessary tubes and catheters and everything that might irritate the patient, cause pain, and that we're just covering with the sedation, not treating the real cause. And above all, it might be possible that in some of the patients only the sedation is needed for the nighttime. So just to conclude, analgesia and sedation are challenging. The goal is to liberate the patient from the ventilation and liberate the patient from the ICU as soon as possible. We should understand what we're doing. So both analgesia and sedation use should be justified, not just from day to day, but daytime to nighttime and hour to hour. And there have been protocols developed during the pandemic that help us facilitate the respiratory mechanical ventilation to avoid unnecessary deep sedation. But these are new lessons. So with that, I thank you very much.
Thank you for addressing this interesting topic. Is there any question from the audience?
I would like to put a question. In your clinical practice, how do you practice? How do you perform? Because I read all the time that we don't have to use benzodiazepine and midazolam. But in my real life, if I have to sedate a patient, okay, I don't have a lot of choice. For the first 2 days, I can use propofol, but PRIS is very frequent syndrome. It's not something very rare. So after that, very often, when you have to sedate the patient with true sedation, midazolam remains only the single option.
Yes, unfortunately, you're right that midazolam might be an option in those patients that require deep sedation for longer. But we, in the clinical practice of our center, we have been using propofol for longer than 48 hours. I know that's against the recommendation, but with proper monitoring, metabolic monitoring, it is possible to use propofol for longer. Sometimes we combine different agents, and I haven't mentioned ketamine, but that's another option that can be combined, and also inhalational analgesia for the sedation for those patients who require mechanical ventilation as a very good facilitator of mechanical ventilation. So, and in clinical practice, sometimes you just have to not fluctuate, but rotate the sedative agents with. If there's no contraindication to performing the spontaneous awakening trial and spontaneous breathing trial, then we just learn from the patient. I would say that.
That was just provocative.
I have one comment or question. You mentioned the use of dexmedetomidine in patients receiving high flow. Do you think that it's the time to rethink about the sedation also in patients receiving positive pressure, non-invasive respiratory support, which is officially somewhere contraindicated, but I think that many centers are starting using dexmedetomidine in these patients?
Well, in our center, we have been using it because it was so much more comfortable for the patients, and because it, in many of them, avoided intubation and actual admission to the ICU, and they could stay in the high dependency units. So I think there was a balance, and all over the world, not just in our center. And I definitely agree that we should rethink the guidelines, because if you can have lower doses and a cooperative patient who, and we can use also the analgesic effect of dexmedetomidine, then why not?
I totally agree, and we also do that.
The level of sedation in any ICU is inversely proportional to the level of staffing. Do you agree with that? Number one. Number two, now dexmedetomidine you have been suggesting. Are there any issues regarding seizures in children when used dexmedetomidine for a couple of days? And you have mentioned about the melatonin in the table. And do we use melatonin in every patient for the night sleep?
Okay, so as I understand, there are three questions. The second one refers to children, and I do not do pediatric ICU, but our pediatricians introduce dexmedetomidine into the unit with very good effects, but it needs further studies and it needs confirmation in the guidelines. That's number one. Does the level of sedation, does it have to be accommodating, does it have to accommodate the level of staffing? This is an easy way out of saying everybody has to be deeply sedated because we haven't got enough personnel, we haven't got enough nurses. I cannot agree with that, because this is against ICU liberation idea. If we allow ourselves to deeply sedate the patients just because we cannot properly take care of them, then maybe there's just fundamentally a fundamental problem with the ICU, I'd say, management or the organizational issues. I would not adjust the level of sedation to the level of nursing care. And with melatonin, this has been discussed this morning, unfortunately, and I really say it with regret. The study from the largest study on melatonin did not show a positive effect, but I certainly used melatonin on the unit to provide better nighttime accommodation to the day-night cycle. So despite the results of the study being negative, this will not change my practice, if that answers your question. Thank you.
Thank you. So we move to the next speaker, Professor Paul Wishmeyer from Duke University, North Carolina. And the title is propofol versus ketamine.
Just a minute. Okay. So as I get started, get my slides up. Just flashing a lot. Let me hit play. So let me ask, how many of you routinely use propofol as your first-line sedative in your ICUs? Good chance. Hopefully there'll be a few less of you when I'm done. How many of you use ketamine for intubation and procedural sedation regularly? Ooh, I like that. That number 5 years ago was about half of what I just saw today. So that's brilliant. So I want to talk to you about these two drugs and the challenges of one and I think the amazing versatility of the other. And here we go. This is what I was told when I was a resident and I would ask about using ketamine. And one story in particular led to the origin of this particular lecture, and I want to tell you that story just briefly because I think it illustrates some of the challenges and benefits of these two drugs. This little girl was named Madeline. She was an 18-month-old, and when I was a first-year anesthesia registrar before I did critical care, I was on a Saturday afternoon, I was called to the CT scanner by the pediatric registrar to watch this child who had a lung abscess, I was told, a lung empyema. I was to watch her have a CT scan just in case something happened to her airway. She was in mild respiratory distress. Now, of course, all of us in anesthesia know we don't watch anything, especially when we're trainees. But that said, I went down, and of course, the child had this very bothersome x-ray with this very nasty lung abscess, but was still active and awake, and was going to have this drained by the CT in the CT scanner. And so they strap her to the board, as they do with little children. The mom is outside in the window watching her child strapped to the board, and the child is screaming, as you might imagine. And the radiologist comes in and says, "Oh, in a minute, young man," that was me, "could you suspend respirations for me so I can drain this abscess?" I'm like, well, that takes more than watching. So I call my attending, and I say, okay, well, these are what I think we should do. I think our station goals are brief, deep anesthesia, it needs analgesia and amnesia as well, maintain the hemodynamics of this impendingly septic child. The child already had positive blood cultures, maintain spontaneous respirations. We'd been told this potentially was a labile abscess that could rupture. And so I said this. This seemed like the perfect drug, and my attending said this, that you're crazy, you'll just give them nightmares, we'll use this. Propofol is the perfect drug for this. It'll put the kid to sleep, they'll do the procedure, the kid will wake up. It's so much safer. So I was outside the room actually when this was going on with the mom, and the attending pushed the propofol. The propofol is given, this happens. What do you think happens next? Right? And this happens next. What do you think that did? So moments later, copious pus is pouring from this child's airway as the mom and I look out from outside the window. The child's sats are rapidly dropping. The attending is trying to intubate the child. He's unable to intubate the child. The little girl, moments later, 40 minutes later, after multiple rounds of CPR, arrests and dies. And she's declared dead on the table in front of her mom and I. I'll never forget it. This child would probably still be alive had we chosen a different drug. Could ketamine have made a difference? Now I want to tell you a story about another child that I used to take care of quite a few young men and women like this. We used to do, at one of the hospitals I worked at, a lot of young Downs and mentally impaired young adults for dental procedures in the operating room. And of course, you have to get them back to the operating room to do that. And this particular young man, Michael, was about a 200-pound 16-year-old who loved karate and martial arts. And he told me that if I stuck him with a needle, he was going to give me with his nunchucks. And so I said, well, okay, obviously starting an IV in this child wasn't a good option. And so I said, I need to get this child to a place I can take him back to the operating room and mask breathe him or put an IV in him there. So I need a fast-acting oral medication that's not given intravenously that provides perfect sedation and won't obtund or cause lack of breathing in this large and potentially difficult airway young man. Ketamine, orally. I do it all the time. This is how you do it, 10 milligrams per kilo PO, midazolam, and you gotta add some glyco to dry them up, and you gotta add some cherry syrup because the midaz tastes terrible. Sure enough, 20 minutes later, it literally works in 15 to 20 minutes. The patient is sedated, cooperative. We went back to the OR, put the IV in, and he went off to sleep. And no one got hurt, which is the best of all things. So, but propofol's everywhere, and it's used for everything. And most of you in the room raised your hand when I asked you about it. It's a panacea, isn't it? If you Google it, there's millions and millions of search results, although most of them are around this gentleman, not really around patient care. But nonetheless, it's a panacea in the OR. But I think Paracelsus says it well, poison is everything and nothing is without poison, and the dose makes either a poison or a remedy. And in the operating room, it is a panacea. But it sounds like the perfect anesthetic, and it is in almost every patient, but the reality is there's some exceptions. And that exception is, I think, the ICU patient in general. Our goal isn't anesthesia in the OR, except for the few times we're doing deep anesthesia for sedated or paralyzed patients who are dysynchronous with the vent, which in COVID has happened more. But what about propofol, not the panacea, but propofol the poison? And it is actually a poison. I'll explain. There's a lot of adverse effects in propofol, the ones you know about the cardiovascular effects and the negative inotropy and heart failure. But it also is mixed in a very toxic fatty acid. It's mixed in an old-fashioned lipid that's immunosuppressant and is really just bad for you. It's like Big Mac and fries down the IV tubing. That's what it's mixed in. Of course, in COVID, we are getting frequent hypertriglyceridemia. And so in this new common disease, this is a challenge that happens in non-hypertriglyceridemic patients as well. It's a mitochondrial toxin at baseline. Mervyn Singer helped me learn this years ago. It actually impairs, and I'll show you electron transport chain. And the other thing it does, I just learned last month, it depletes zinc. It binds zinc, and you pee out zinc. And these patients get very zinc deficient if you use it more than 5 days. And so I didn't even know that, but a pharmacist taught me that. And then there's the PRIS, the propofol infusion syndrome, which I'll talk a little bit about, but I won't belabor. And then the last thing is it's not an analgesic. And so the patient is often too sedated to assess pain, and so you're not treating pain appropriately. There's no way to accurately assess pain. 2 seconds about PRIS. I sadly saw a patient die of it, which got me more interested in giving this talk when I was a young attending. Again, it can present in lots of different ways. It looked like about 90% of our critically ill patients, dysrhythmias, metabolic acidosis, rhabdomyolysis, renal failure, all these things, right, bundle branches, all the things that ICU patients do every day. So it's very hard to diagnose. This is why it happens. It inhibits the mitochondrial transport chain. And so it begins to kill your muscle. And your muscle cells die, and they pour out various mediators that lead to the cardiac arrest that ultimately follows. And so that's why the people at risk tend to be people who perhaps are the most difficult to discern these symptoms in. Males with large muscle masses obviously have it the most. You can't give this in children. It's black boxed. It caused significant excess death in a pediatric study, and it's been black boxed for years. But all these other things, this is most of my ICU, that it's theoretically contraindicated because of the PRIS. So that describes almost all my patients, and so how would you monitor for it? It's very difficult. But maybe propofol is so much better than our other sedatives, we should consider using it. But even the TV doctors know it's not. I mean, the data's gotten a little more equal now, but when the initial trials came out, right, dexmedetomidine was better in multiple ways. The other thing that a couple studies have shown now is dexmedetomidine reduces polyneuropathy versus what propofol does, because propofol kills your muscle and probably contributes, in 2 studies at least, to ICU-acquired weakness. And in fact, there's some direct physiologic studies that shows it injures the muscle directly and causes weakness. And so again, although our more recent studies of lighter sedation haven't shown much difference, they have definitely not shown that propofol is better. And dexmedetomidine is cheaper. The data for both Europe and the US, this is just the European study since we're in Europe, shows it costs less to use dexmedetomidine. So if you have to give it, can you do it more safely? Again, you've probably been taught this, but if you haven't, keep it less than 50 mics per kilo per minute. And more like 30 or 40 is better. For less than 48 hours is ideal. Although there's a recent study from 2015 that showed that PRIS can develop in shorter periods of time and at lower doses. And it can have sort of atypical features and easily be missed. And so 48 hours and that 50 mics is not necessarily perfect. So ideally, don't use it at all if you don't need to, or at least for very short periods of time. Use Dex because it's cheaper. Or you have another option for lots of different reasons. Ketamine is a good option in a lot of different versatile ways. And that's what I want to tell you. But this is a thing occasionally you'll hear. But of course, as I learned early on in residency, you have to wake up, at least your patients do, to have the nightmares. And they're easy to treat, I'll show you. So is this the best drug perhaps you aren't using as much, although it's nice to see so many here using it in the US, not nearly that many hands would go up. Most of my residents and trainees have no idea how to use it. Again, it's a dissociative anesthetic. It's potently analgesic, potently amnestic, doesn't decrease respirations. It causes dissociative anesthesia, and I'll show you an example of that in a little bit. And it's really good at maintaining respiratory and hemodynamics. And then this nightmare thing is very easy to treat, as I'll show you. There's a trick that you need to do, and it's quite easy to do. And it's reemerging, and I think COVID's really helped it reemerge. It's being used for ICU sedation now pretty routinely in the US. And this was a great paper that was published with this really great infographic, if you want to look this up, on the reemergence of ketamine from use from everything from alcohol withdrawal to acute pain management to asthma to status to agitation. And so dosing, these are the doses, 0.5 to 1 IV. This is a good induction dose for anesthesia. If you're going to induce for intubating, more like 2 milligrams, it's 5 IM and it's 10 PO, and it's a brilliant PO drug. And if you really need to control a really violent patient, I had a patient once that was throwing chairs at nurses, 5 into the leg per kilo, less than a minute. They'll be asleep calm and they won't lose their airway. And so always pre-medicate with glyco when you can. They'll salivate sometimes. It makes them a little more difficult to intubate. And then the key thing that I hope you take away that you always do when you give this drug to stop the nightmares is always give midazolam at induction. 1 or 2 milligrams is all it takes. I usually only give 1. And then the key step is 30 minutes after your last dose, let's say you're using it for procedural sedation, give a milligram or 2 more. That quashes the emergence delirium. And I've never had a patient tell me when I've done this that I was a burn attending for many years and I used it every day, that they woke up and had bad dreams. And I'll show you that in video in a minute. So again, it comes on very rapidly. Even IM, it comes on very rapidly. Its half-life's about 30 to 40 minutes, and its duration of action don't use it intranasally. I know the ED docs love to do this. It's really erratic, so it's not a great intranasal drug. You don't need to adjust to renal failure. Some just brief effects. It preserves hemodynamics because it releases catecholamines indirectly. So if you're really depleted or have really chronic heart failure and have low catechols, you can drop blood pressures and drop cardiac output. It can definitely get you. No drug is perfect in that state, and that's when you might use etomidate, not in sepsis, obviously. So that's one thing to be worried about. Be careful on heart failure, pulmonary hypertension, and atrial arrhythmias. It can cause some pretty good tachycardia. I always have some labetalol in the room when I use it, especially in young people. It will keep people breathing even at high doses. This is the perfect drug for awake fiber optic intubations. I never use opiates in them. I only use ketamine. I can walk that scope and sit it on their carina. They won't move. I just did it 2 weeks ago, actually, with a medicine registrar who'd never done it in their life. Prevents bronchospasm, so it's really nice in these conditions. It has a lot of good pulmonary and respiratory efforts. For the GI people, I'm a nutrition person. It improves gastrointestinal motility, unlike any of the other sedatives, and may improve successive enteral feeding, and it reduces serum fatty acids, unlike propofol, that clearly causes hypertriglyceridemia. So some brief literature review. I won't spend too much time, but I think there's some worth knowing. Traumatic brain injury, they used to say don't use it. But that's not true. Those were medical student studies done without controlled ventilation. And so the elevations in CO2 and the increases in ICP were a phenomenon of medical student research. When you control ventilation, it doesn't cause that and is very safe to use in head injury, and it's actually neuroprotective. There's a lot of laboratory research going into the isomers of this drug as direct neuroprotectants. It's very useful in status. I've seen it used lots of times for this. This is one of the other uses you can bring out when things are failing. I don't work in the neuro ICU very much, but I do take care of some patients like this in overflow, and so we've definitely used it. This is where I use it the most. I intubate all my patients with it because my registrars never see it used otherwise, and it maintains spontaneous respiration. So if they get in trouble, I don't have a patient who's got a bad airway who can't then breathe spontaneously. This has been studied. It was shown to have similar intubating conditions and potentially lower SOFA scores in septic patients versus etomidate. You can guess why. It doesn't cause adrenal suppression. And so it seems to have a benefit in the septic patient, and it's a good alternative. I use it almost in everybody. So refractory status, there's a fair number of studies now of this. I can think of one or two patients, actually Ivor Douglas, who you may have heard speak here. He and I, we used to work together at University of Colorado. We can think of one patient in particular, had a PCO2 that was unmeasurable after all of the normal asthma treatments. We put her on a ketamine drip. She was down to a normal PCO2 by morning. And so I can definitely think of patients that I've brought this out. I run it at 1 to 2 milligrams after about a 100 milligram bolus, 1 to 2 milligrams per kilo per hour. And that seems to help some people I can think of. Ketamine as ICU sedation is a newer thought. There's been some reviews on this in the past. There's some benefits and reasons to do it. It usually preserves blood pressure and heart rate better, and can decrease airway resistance and airway issues. There's a multi-center trial that was presented to Critical Care Medicine Congress last year that looked at a large number of 390 patients in a retrospective study, and they found it was significantly increased with median times in goal pain ranges, goal sedation scores, with no median time spent in delirium. So the concern would be delirium, right? And they did not see that. And so angular sedation, the doses run anywhere from 0.06 up to 1 and 2 milligrams per kilo or per hour. So those are the doses you can use. So some quick clinical pearls. Sedation for procedures. You can do lots of things with it, obviously. It's the ideal thing for many of these procedures. I use it all the time, even for central lines. If you've never laid under the blue drape, you should think about it. This is a child that I knew that was getting his lips sewn up. You can see he got ketamine. Make sure they're NPO. That is one note. It does not prevent airway reflex issues. They can still aspirate. So always try to make sure they're NPO. You're always at risk if they have a full stomach. So take that seriously. Have airway equipment available. I've never had to intubate somebody doing a procedure with this, but it could happen, and you want to be ready. These are the doses again. Glycopyrrolate, midazolam 30 minutes after. Always mix it in cherry syrup because the midazolam tastes terrible again. And you can see this child went through the process. There's mom holding the child. That's them sewing to the lip, the child looking up at the sky, and everything is better. So why do I use ketamine in my ICU day every day, and why do I hope you do too? Well, I'm not only an ICU physician, but I've been an ICU patient. And I've laid under that drape, and this is my end here. I've laid under that drape and had that big needle come at my neck. And I've laid on the CT table and had them drive spikes for drains into my glutes to drain abscesses. And I remember every second of it. And I wish I didn't. I still think of it. And until you've laid under that drape, don't underestimate what that patient's feeling, and you can take that away. That's the joy of being an intensivist and anesthesiologist. Someone who's good at this can take away suffering, right? And I got to experience this firsthand. I was skiing with my children a few years ago. And my youngest, who now is 12, but was only 9 then, was skiing down the hill in Colorado in the US at the end of the day at Breckenridge. And a drunk teenager came flying at him, and I skied out in front of him. And he hit me, pushed my arm into a barrel, and that happened. And I was very angry because I knew it happened. It almost came through the skin, and I was very frustrated. My hand went numb, my hand went cold, and so I got taken to the emergency room in Colorado, where I worked at the time, up in the mountains, and the resident there, who was a new attending actually, who I trained as a resident at University of Colorado, said, "We'll just put some lidocaine in that wrist and we'll put it back." And I'm like, "The hell you will. That's not happening." I said, we'll talk you through, my wife is an ICU physician assistant, I said, "We'll talk you through a ketamine sedation of me." So we did that. This is me, sedated, getting my wrist relocated. And I want you to listen closely. This is me waking up with a little midazolam.
How are you feeling?
You don't really feel anything.
Well, that's great.
Until you're not right here.
Where are you?
I'm in bed, but it's like I'm watching a movie of me in the bed.
That's
It's
neat.
very interesting.
Are you the only star in the movie?
No, you're in the movie with me.
Hey,
And there was a doctor who came in to go to the movie with me.
what were they doing?
I don't know what they're doing. They talked to me. Be nice. Well, it's very friendly.
Good.
But you know, like in Pixels, where everything kind of moves in the little pixels?
Yeah?
The whole room looks like it was pixelated. I remember it.
It kind of moves
Like the movie.
a little bit slowly.
It's very effective. I don't remember any of the relocation, and nothing hurt for hours. So again, and I have no bad memories of it. I remember being in a temple and everything being pixelated. That's about it. So is ketamine the best drug you've never tried? I hope all of you do if you're not using it now. Is propofol a panacea? It's not. It's great in the operating room, but it has risks and maybe a poison in the ICU. Try to use it less. You have better choices, I think. Not in every case. There's times you need it, but in many cases. And again, if this isn't the best drug you've never tried, think of this little girl the next time you think about how you're going to sedate somebody for a procedure. Because had we chosen it here, she'd probably still be with it. And we could all do better for patients like that. And for the procedural sedation, I think our patients deserve. And then we'll be happy, and most of all, our patients will be happy. And with that, I'll be happy to take your questions and happy to share these slides. Thank you.
Thank you, Paul. Any question from the audience? Who use ketamine in practice, in routine? I can. Okay. We use it for a long time in patients with traumatic brain injury, and based on RCT we did, and the National Agency in France stopped it, and because of stupid reasons. But
That's strange.
Yeah.
How many of you use it for ICU sedation as an infusion? Oh, a fair number of hands in the room, actually. That's nice to see. Yeah, more and more U.S. centers. There's protocols. If any of you are interested in some of the protocols, the University of Michigan has a great protocol for ketamine use as a sedative, and I'm happy to share that with you. I have it. I can email it to you. But yeah, there's some really brilliant protocols out there about using it as an ICU sedative. In COVID, as the propofol issues came up and not wanting to use benzos, this became an alternative in many centers to prevent using benzos. And you saw there was that large 390 patient retrospective study where they looked at its efficaciousness in that setting, and it was quite successful, that group's thought.
there is a question.
Yeah, or actually, to be honest, it's more of a comment.
Yeah.
I am a fan of ketamine, and I use it a lot and have used it a lot. I think, as you described when I was working on the ambulance, if you can explain to someone you have a dislocated hip, I'm going to give you a drug, you might be seeing odd things. People are fine with that. They would rather see star shapes than be in pain.
Yep.
And then the same in the ICU. When we use it as a low-dose infusion for pain, you can say, okay, I'm going to titrate this drug. You might, see things or feel uncomfortable, and if you would rather stop it and be in pain, that's fine.
Same.
But I do feel you're underselling the nightmares a bit. I think in the emergencies, the obstetric emergencies where we use ketamine, to me, the mothers after, I think they seem to be not in a good place for hours afterwards. And I also think the trauma patients where we use ketamine and then we continue with infusions and then they stabilize quite quickly and we can actually wake them up pretty quickly in the ICU. They're not in a good place either when they wake up.
And that's why I really will emphasize, especially when you use a procedural sedation, the midazolam component at the end of it in single doses is really critical. The emergence is really a key point. I've definitely seen it given to people by other physicians where I've taken over their care where they didn't do that, and I've had the patient be in very bad places as well. I've really been struck by that.
So just to say that has not fixed it for me, unfortunately.
Interesting. And clearly, not all the patients have ever been able to tell me, of course, all their experiences, but I have found that when I've asked them later, the majority of them didn't remember waking up from it, a lot of them, because of the midazolam, or didn't tell me anything unpleasant. So, but you're right. I think every patient is different, and you have to respect it.
I'm afraid we have to conclude for time constraints. So thank you to all the speakers for this wonderful session and for attending in the last day of the Congress. Thank you all.